Well, good afternoon. First, I want to thank Aspetar and particularly Dr. Landreau for inviting me. As we heard this morning, handball, like many other sports, has become a sport of contact with frequent contact, violent, causing falls and injuries. Today I would like to draw your attention on the need of complete rehabilitation after acromioclavicular joint separation. Click. Merci. This is a graph of congruence. This joint is a low congruence articulation. And if diagnosed, the acromioclavicular disjunction is not always scaled to return to play at previous game. From sprain to dislocation, it affects the stability of elements of this articulation. It's accompanied by lesions in 50% of cases. The mechanism is well known: direct trauma to the shoulder, fall, contact with the opponent. The consequences, short-term consequences, is a short and simple immobilization arm in a sling. Pain is resulting from the fall, the shock, and stiffness protection resulting from the pain. Then dyskinesia installs, resulting from pain and immobilization. Loss of motor control then, maybe instability, we talked about that, and in the long term, osteoarthritis, lesion, yes, and the sport movement is affected. The whole kinetic chain is affected. Rockwood classification is from type 1 to 6, from sprain to dislocation, and rotator cuff dislocation too. Today we're talking about conservative treatment. It's reserved for type 1 and 2. It takes place in 4 phases and only ends when the players find his position. Players are always very happy to go back to play. They want to go back in 1 week, they feel pain, but they want to play. Coach wants the player to play too, but we have to wait. We have to persuade them that they have to rest, to be immobilized in 1 or 3 weeks, and then to be re-educated through. Principles of the treatment are treating pain, of course, regain mobility. Besides the management of pain, recovering mobility is very important before to go through. We have to stabilize these corrections, and strengthen program will be the objective targets. About kinesiotape and strapping, I just wanted to talk about it quickly because personally I do not use it until the player goes back to play, only if the player requests. Because of the big traction exerted by deltoid and trapezius, I think it's not very interesting and first intention. It's reassuring the patient and may be useful when he goes back to play, but not before. We have to watch out. Both shoulders has to be tested regularly in different positions. Passive mobility, then active mobility. In seated positions, and conventional tests are carried out to search associated injuries. You have to test both shoulders, I think, once a week. Then I want to focus your attention about dyskinesia. So this patient, this first one, yeah, he had injuries 2 years ago, but he didn't have rehabilitation. He started to play 3 weeks after acromioclavicular joint separation. And now, when he tries to climb dips, you can see his right shoulder. He lost motor control. The first one is okay. Then, with muscle fatigue, he cannot climb anymore. You see the first one, then the second one, and the third one. Okay, muscle, there is no more response. And this one shows Rodney told me winging. This is winging, yeah. So the left side is okay. The right side, you know, he lost scapulohumeral rhythm. And this player is back to play. It was normally he would have been rehabilitated. This one, same dislocation 2 years ago, rehabilitated. You can see both shoulders have good motor control. The other one, no rehabilitation, 2 years without playing, no more muscle, and you can see two scapulas. Alors, tu m'avais dit que je peux cliquer là, if I click between? No. One more time. This one, quick and good. And this one, very slow, no more muscle. So conservative treatments is reserved, I tell you again, for stages 1 and 2. It takes place in 4 phases and only ends when the player is able to play. We have to correct malfunction, to dynamic stabilize correction, stabilize restore balance and operations, and back to play. The first phase concerns manual therapy. You have to respect good joint realignment to go through. We're using manual therapy to release tension in trapezius and deltoid. Working below 90 degrees elevation and abduction is recommended. We also mobilize clavicle, and then at the end of this phase, you have to return to complete mobilization. It's very important to return to complete mobilization before to go through. The second phase will determine correction obtained. The player learns to stabilize and recognize this position of function. Building muscles begins without seeking trapezius and deltoid, then working coaptation muscles. Personally, I do not use weight in this phase, but elastic bands. Another example, this one was rehabilitated 2 years ago. And always working both shoulders. Then we stabilize with other exercises. Then you can use weight in progression. The third phase, we work to strengthen the shoulder muscle, coaptation. This period also addresses proprioception, and we work the entire kinetic chain, starting from the closed chain to go to the open chain. You have to work compressive forces to restore the reflex response. Then, active stabilization and strengthening of coaptation muscle using Klein's balls and going from stable plan to unstable with distraction, which is very important. And the player has to recognize his best position of active stability. Open eyes, close eyes, and working with an opponent. The last phase considers that the player is able to play, but we have to go with him and accompany him through to work the sport gesture back. We work with the whole body, and it's the relearning of the fall. Player is afraid of falling again. Relearning of the fall begins from vertical to horizontal position. The player has to be back to the contact with the opponent and the contact with the floor. We work with different height, different speeds, and we learn him to tuck chin, hit the ground with the arm, which are the instructions of all falls. On this picture, this is from volleyball. Volleyball players, when they are training, are always falling a lot of time. They jump, then they plunge. Land, yeah, thank you. They land, and they had to hit the ground. You can tell me that they have no time to hit the ground when they are playing. They are throwing the ball, they are falling on the dominant shoulder, on the other one, and probably they don't have time to hit the ground and to tuck chin, but it must be a reflex. Then you can work with Klein ball and different mestres. Maybe surgical treatment will be necessary. Then rehabilitation will have two phases. It's just a question of time to respect. From day 1 to day 28, it's an immobilization. You have to be low shoulder position to mobilize inflection and abduction and mobilize scapula. Then the patient must do self-rehabilitation. After day 28, he must be able to play, and the principles are the same than for the conservative treatment. The evolution of these injuries is satisfactory on types 1 and 2, when they are relocated to through. In other cases, it depends on their care. I am not here to speak about surgical treatment. I think that Dr. Landreau will do it better than me. So if you have to take a home message, you have to take care about these injuries. I can tell that in 80% of cases, they're neglected, and the player is back to play too early. So you have to manage it individually and work through the kinetic chain to recurring gesture. I thank you very much.